Greetings from Kuala Lumpur, Malaysia. I am Zhiqin Wong, a consultant gastroenterologist and hepatologist from the National University of Malaysia. First of all, I would like to thank the organizing committee and Dr. Muhammad Elborey for the kind introduction for me to share with you some insights on therapeutic advances in GERD, medical surgical endoscopy treatment at this prestigious meeting in AHC 2021. This is my disclosure. Today's agenda will be on introduction, diagnosis, and treatment modality, covering all aspects and some future directions and unmet needs. Gastroesophageal reflux disease is a common disorder with an increasing prevalence. Proton pump inhibitors are effective in achieving symptoms control and preventing complications. Approximately 40% of patients have persistent GERD symptoms despite PPI therapy, with increasing awareness with regards to the side effect of long-term PPI use, while laparoscopic anti-reflux surgery remains the gold standard of PPI refractory GERD. Less invasive anti-reflux interventions are highly desired. Symptoms and complications resulting from the reflux of gastric content into the esophagus or beyond into the oral cavity or lung. Erosive esophagitis, non-erosive reflux disease, and Barrett's esophagus are the three phenotypic presentations of GERD. This is a global distribution of GERD according to country. In the normal anatomy, as we can see on the left, functional valve present, where the type is tied to the scope. When it closes, there will be no reflux, and maybe there will be some physiological reflux, which are infrequent and mild. When the abnormal anatomy occurs, it poses a dysfunctional valve where it causes symptomatic GERD, which can be frequent and intense. The solution is to restore the anatomy to normal by repairing the valve to resolve the symptoms. So under normal circumstances, we have anti-reflux barrier that is anatomically where integrity has been attributed to esophagus, diaphragm, stomach, and LES. And in GERD, we have deficiencies in phrenoesophageal membrane, where its deterioration results in a loss of elasticity and GEJ is not returned into the abdominal cavity following swallow. And the loss of angle of heat decreases the barrier strength, presence of hiatal hernia, where the GE junction is above the diaphragm, reduces the function of the valve when in a negative pressure thoracic cavity environment, therefore increases the TLESR. The transient lower esophageal sphincter relaxation will decrease the valve competency as well. So we all know very well the symptoms of GERD. The cardinal symptoms being heartburn, GERD, and there's also reported water brush, chest pain, discomfort, dysphagia, belching, epigastric pain, nausea, and bloating. And with extra esophageal symptoms, sometimes they presented with cough, hoarseness, throat clearing, throat pain or burning, wheezing, or sleep disturbances. GERD diagnosis mainly by endoscopy or histologic, and we will assess the severity of the assessment being high or low risk, whether continuous on demand, step up and de-escalate therapy as required. The prediction of the cause whether the patient require further intervention, endoscopy or surgery will require diagnosis by HRM or pH in the presence of hiatal hernia. Very importantly, not to miss the neoplasia risk via endoscopy, eradication therapy, or dysplasia, where the presence of dysplasia or any biomarkers has actually proved to have neoplastic risk. This is our famous early classification of esophagitis, where we can see on the left top diagram, grade A will be one or more mucosal breaks and no more than 5 mm that do not extend beyond the top of 2 mucosal fold. Grade B, you have one or more mucosal break longer than 5 mm that do not extend beyond the top of 2 mucosal fold, where you have grade C, one or more mucosal break continuous between the top of 2 mucosal fold, but is less than 75% of the esophageal circumferences, where grade D, you have coverage more than 75% of esophageal circumferences. An overview of the treatment modality. Patients with typical symptoms of GERD received empirical treatment with a proton pump inhibitor and do not undergo diagnostic testing. But patients with alarming symptoms such as dysphagia or dinophagia, anorexia, weight loss, and upper GI bleed, investigation with upper endoscopy is warranted. This diagram shows a simple diagram with managing esophageal reflux disease. When there is no alarming symptoms, you will start an empirical PPI therapy of 8 weeks and check for responses. When there is an alarming symptoms, EGD is warranted. And looking at the finding from there, we treat accordingly. What is abnormal, you treat according to the mucosal findings. And if it's normal, then we will consider necessary referrals and whether the patient requires a further investigation by pH monitoring. So optimize patient-centered care in GERD is very important to secure a diagnosis, explain and assure an educated patient with some diet modification, and we aim to treat to target, and we further look at the refractory disease if there's anything arised. So lifestyle modification, obesity has been demonstrated to be an important risk factor for GERD. And reduction in BMI by 3.5 units actually reported a 40% reduction in the frequency of GERD. Patients who report that tobacco, chocolate, carbonated beverage, onion, tomato sauce, mint, alcohol, citrus juice, spicy, and fatty meals as exacerbate symptom. However, there is actually lack of evidence that reported after the cessation there's improvement in clinical or physiological parameters. So the lifestyle modification that we can actually advise the patient are try to avoid eating at least 3 hours prior to bedtime, elevate the head of the bed during sleep, avoid the right decupitous position in the bed, and turn off the lights, and treat with PPI. The symptoms are primarily during the nighttime to be given before the dinner, and you could split the PPI dose either AM or PM before meal. Add on a H2RA if needed, some Gaviscon before the bedtime, and consider some non-medical therapy. So bothersome GERD will require medical therapy related despite lifestyle modification. You can add on some GERD, H2RA, PPI as mentioned earlier. The other option are TLESR reducer and prokinetics. So PPI are considered the most effective medical therapy for GERD. It produces profound and consistent acid suppression and demonstrate different level of satisfaction that range between 56 to 100% as compared with other anti-reflux medications. So the currently available proton pump inhibitors, as this long list over here, most of them are given 30 minutes before meal for an optimal pH control, except for dexlansoprazole, which employs a dual delayed release technology, which leads to a sustained plasma drug concentration. It can be taken anytime before or after meal, any time of the day. So as mentioned earlier, the overall rate of symptom relief of PPI in the patient reported to be 51%. PPI can provide symptom relief in approximately 57 to 80% of patients with erosive esophagitis and about 50% in patients with NERD. Healing of erosive esophagitis of all grades can be obtained in greater than 85% of GERD patients undergoing treatment with a standard dose PPI. So how do we optimize PPI therapy here? We can optimize with the together with the lifestyle modification, improve the compliance, ensure the proper dosing time using a split dose regime, or simply switch to another PPI if one does not work. So side effects of PPI, it has been long been considered a very safe class of drug. However, the last decade, there has been some reported side effects, namely the nutrition deficiency, the magnesium B12, increase the risk of gastroenteritis, travelers diarrhea, ulcerative colitis, osteoporosis and bone fracture, microscopic colitis, IHD, CKD, and dementia has been reported. So again, we come back to if the patient does not respond to PPI therapy after 8 weeks, we warrant further investigation and pH monitoring. If they show abnormal results, we would want to either optimize the medical therapy, and we would want to think about surgical endoscopic therapy. So if it's normal, we'll consider as functional heartburn or reflux hypersensitivity. So word on refractory heartburn, it is defined as symptoms of reflux of gastric content that do not respond to double dose of a PPI given for at least 8 weeks. Reflux hypersensitivity and functional heartburn are the leading causes. So medical options for patients who are poorly controlled on twice daily PPI are very limited actually. So baclofen, which is a gamma amino butyric acid agonist, is given around 5 to 20 milligrams 3 times a day. In residual acid or weakly acidic reflux, by reducing the rate of TLESR and thus gastroesophageal reflux. Not effectively controlled by twice PPI, who continue to demonstrate residual G reflux can try baclofen. No significant differences in the overall adverse event between the baclofen and placebo, and all reported were very mild and moderate. Some of the neuromodulators here: tricyclic antidepressant, selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors are other options. So if the patient does not respond, as mentioned earlier, in the pH impedance test, when you have demonstrate abnormal reflux, you will want to further explore optimized medical therapy and probably explore into endoscopic treatment or anti-reflux surgery. But if the pH study is negative, patient warrants the esophageal manometry, mainly to look for any motility abnormality like achalasia and ineffective motility. But if it is normal, again, then we will classify them as hypersensitivity or functional heartburn. In the hypersensitivity group, they may respond to anti-reflux surgery or endoscopic treatment. And if it's the functional, you will want to focus on neuromodulators and some psychological intervention. What is surgical therapy available? The candidates who are suitable for surgical therapy are those who are having side effects, poor compliance, and not interested in medical therapy, and wish to continue some chronic medical therapy. And they are symptomatic with large hyperhernia, presence of regurgitations, demonstration of abnormal pH on the maximum PPI dose, and symptoms actually correlate with a non-acid reflux while on maximum PPI dose. So some investigation before the surgery, as mentioned earlier: pH testing, HRM to exclude motility disorder. So patient with typical heartburn that's fully controlled on the PPI, then those who demonstrate an abnormal ambulatory pH monitoring with a positive symptom correlation appear to have the best surgical outcome. Anti-reflux surgery is not recommended in PPI non-responder. So Nissen fungalplication, Mayo in 1911 did the first repair of the hiatal hernia. Nissen in 1956 first successful anti-reflux surgery. Subsequently, in the 90s, laparoscopic surgery popularized, and there has been many fungalplication done since then. So Nissen fungalplication is a laparoscopic surgical fungalplication that's presently the most common technique performed in GERD patients. Comparative studies between anti-reflux surgery and medical therapy demonstrated mixed results in patients with GERD. Severe side effects such as dysphagia, gas bloating syndrome, and flatulence and intended effect may only be temporary, as up to 60% of patients will require anti-reflux medication regularly in the decade afterward. This is a pictorial diagram showing what's anti-reflux surgery. And this JAMA report actually reported, in the surgical group compared to the medical group, anti-reflux medication is restarted in 62% of the individual. Another procedure called the Lynx procedure is a recent addition to the surgical repertoire for GERD in the Lynx reflux management system. It is a ring that's placed around the lower end of the distal esophagus for the laparoscopic, and it helps to augment the lower esophageal sphincter and thus prevent gastroesophageal reflux. So this pictorial diagram shows that when there is a defective LES, it allows the reflux back into the esophagus. So a Lynx device is placed around the LES during the laparoscopic procedure, and it is designed to augment the LES pressure to prevent the reflux, and it also designed to accommodate a normal swallow function. So initial experience in a small series shows a reduction in PPI usage in overall improvement in quality of life that was reported in greater than 90% of patients. When compared to Nissen fungalplication, the Lynx device has shown similar improvement in quality of life and symptomatic relief with fewer side effects but lower PPI elimination rates. Although the initial result is promising, long-term efficacy, durability, and safety get to prove larger group of patients. So let's come to endoscopic therapy. There have been several endoscopic treatments for GERD that has been developed over the last 2 decades. They are the radiofrequency energy delivery to the LES, the Strata procedure, the transoral incisionless fungalplication TIF using esophageal device, the anti-reflux mucosal resection and anti-reflux mucosal ablation, the endoscopic anterior fungalplication using Medigas ultrasonic surgical endostapler. Of these, the first 3 is the most evidence. So I will talk about the first 3. So what about Strata device? It's actually developed in the 2000s and works by delivering the thermal energy to the lower esophageal sphincter, which is postulated to increase the sphincter thickness through a scar tissue deposition, thereby reducing the reflux. However, in the meta-analysis and randomized control trial, Strata treatment did not reduce the percentage of time when pH is less than 4 or increase LES pressure or ability to stop PPIs. So pictorial diagram is showing how it works: presence of weak muscle causing reflux. Strata therapy treats the muscle with radio frequency energy. And when the energy is generated, post-strata, thicker muscle actually prevents the reflux. So transoral incisionless fungalplication, in short we call TIF, is a creation of a partial gastric wrap around the lower esophagus with an esophagus device mounted on the endoscope. So this is a picture showing presence of small hernia with the esophagus devices. A wrap of 270 degrees is created, and as shown on the diagram here, you look at the thickness of the wrap being created. So this is a cartoon showing a 270-degree wrap and as long as a 3 cm into the esophagus. So what are the indications for TIF? Is more than 18 years old, partial and incomplete response of daily GERD symptoms with PPI more than 6 months, Hill grade 1 to 2 flat bowel, proven GERD by the endoscopy, pH study, or barium imaging, hiatal hernia 2 or less cm, and abnormal pH or endoscopy while on PPI. So how do we assess the GEJ by Hill grade classification? As you can see, this is Hill grade of 1. Hill grade of 2, you have streak is slightly less well-defined and open speed respiration. In grade 3, you have ridge is effaced and the hiatus is petulous. Grade 4 is wide open and all time, and the sphincter is displaced axially. So measurement of axial and transverse hiatal hernia is important in deciding whether the patient is suitable for TIF procedures. Patient selection is important. We'll mainly choose those with anti-reflux barrier disturbances here when LES incompetence, Hill class 2 or 3, Hill class 2 and Hill class 3 with reducibility. These are the ideal group for the patient with TIPS. Look carefully into contraindication of BMI more than 35, hernia more than 2 cm, presence of Barrett's, esophagus, portal hypertension, gastroparesis, esophageal surgery, pathology. All these are contraindication for TIF procedures. So when to use TIF, again, this is a repeat of the earlier slide. Of course, before the conventional surgery, patients who are non-responding to pharmaceutical therapy who fulfill the criteria should offer TIF procedure. So symptom control and PPI reduction or cessation of at least 6 months viable option for selected group of GERD patients with hiatal hernia and preserve esophageal function. Large randomized trial comparing TIF with PPIs showed symptomatic control in 67 versus 45% of patients. So TIF is associated with reduction of esophageal acid exposure time and the MISTER score reduction. So a meta-analysis was performed compared TIF with nasal fungalplication, a shunt procedure, and PPIs. TIF was associated with larger increase in quality of life measures, while nasal fungalplication had a greater ability to improve physiology parameters associated with GERD, including LES pressure and the percentage of time the pH was less than 4. So the impact of the device modifications, as we can see in the LES pressure and the amount of rep that's being performed. At the moment, what's available is the TIF 2.0 version. As you can see across, the pressure zone increases as compared to the baseline GERD. Of course, nasal fungalplication provides the highest pressure zone. So TIF versus surgery, the long-term side effect profile reported. There has been no report of dysphagia, gastro symptom, and flatulence so far. However, in anti-reflux surgery, dysphagia is reported as high as 24%. Many of them report gas bloating symptom. So serious adverse event rate of 2 to 2.4% in two largest meta-analysis. Majority are with the first version. It has been decreases with time, likely due to operator experience and device refinement. The reported adverse event are perforation, positive bleeding, and pneumothorax. So what are anti-reflux mucosal resection? This was developed by Professor Haruhiro Inoue from Tokyo, Japan, which is an anti-mucosal vasectomy for GERD patients. So potential anti-reflux effect of arms here in a patient without sliding hiatal hernia will be required to establish arms as an effective technique to control GERD in this setting. So they have published a clinical outcome of endoscopy anti-reflux treatment methods. Yeah. So in 2014, they reported arms which utilizes the ESD or an EMR cap to rebuild the flat valve of the gastric cardia by scarring of the artificial ulcer. Subsequently, in 2018, they developed an anti-mucosal reflux ablations, where they apply ablation instead of mucosectomy as an alternative therapy for PPI refractory gut. And this cohort actually reported patients between April 2012 to 2019, where in arms, ESD or EMR cap in the gastric mucosa was performed to create an ulcer. In ARMA, mucosal ablation was used with a triangle tip knife and spray coagulation mode utilized to create the ulcer. So the efficacy was actually evaluated by the FSSG score and with objective findings before and after the procedure with acid exposure time and reduction of the MISTER score by the 24-hour multi-channel intraluminal impedance pH monitoring. So conclusion is both ARMS and ARMA were effective anti-reflux therapy method for PPI refractory gut, which improve gut-related symptoms and objective acid reflux parameters. ARMA may be advantageous on its easiness and simplicity regarding operative time. So there's a picture showing this is ARMS, and this is 2 months after ARMS, and this is ARMA, and this is 2 months after ARMA. You can see the creation of the ulcer and stricture. Yeah. So again, another pictorial diagram showing the similar concept. So anti-reflux mucosectomy with cap-assisted endoscopy mucosal resection is an effective and safe treatment method for gut in terms of short-term outcomes. And another paper published by the same group, Professor Inoue, concludes that the pilot study shown on ARMA is a new endoscopic treatment for PPI refractory gut. It is simple and improves gut symptom-related and objective acid reflux parameters. So again, the patient selection is very important. PPI refractory gut, mild to moderate GE junction morphology impairment with hiatal hernia less than 3 cm. And it is unlikely that ARMA will completely replace a laparoscopic anti-reflux surgery, as ARMA may only be effective in the absence of a significant sliding hernia. So how can we do better? We have to be careful with patients with psychological issue and hernia more than 3 cm with esophageal motility disorders such as achalasia or incomplete lower esophageal sphincter relaxation. This kind of patient should be excluded from endoscopy treatment. So we'd like to conclude that the diagnosis of gut is mainly symptom-based related and often does not require endoscopy confirmation, but endoscopy is warranted in patients with red flag symptoms such as dysphagia, anemia, weight loss, bleeding, and recurrent vomiting. So PPI as a first-line medical therapy, H2RA are mainly used as a breakthrough nocturnal symptoms. Endoscopy and surgical options exist and promising, but are pursued only if medical therapy fails. What are the future direction? Probably ARMA versus arm versus tip. Do we need a larger study? Probably RCT comparing with fungalplication with long-term follow-up is required to confirm these results. Expanding indication on an existing endoscopy therapy. ARMA in the PPI-dependent patient probably merits evaluation for this growing patient population with medet benefit. And gut after gastrectomy includes sleeve gastric, which is not an appropriate indication for LARS. Yeah. So with that, I thank you.